Hey, thanks, Christine. Good evening, everyone. Welcome. On behalf of the American Neurotology Society, I'm delighted to have you join us for tonight's webinar. This program is part of the Lateral Skull-Base Collaborative. It's a joint educational initiative bringing together the ANS, the American Head and Neck Society, and the North American Skull-Base Society. The goal of this collaborative is to bring our specialties together around the complex diseases that we manage. The ANS is pleased to lead tonight's webinar on temporal bone cancer. This group of experts tonight has worked very hard to put on this valuable educational product. I think you'll witness tonight just how a carefully orchestrated multidisciplinary team can significantly improve outcomes and improve the quality of lives of the patients we treat, which is what we're here for tonight. I'd like to thank the faculty. I'd like to thank our partner societies for making this collaborative effort possible. But I'd like to thank Christine Din especially, who originated this idea and has worked tirelessly to make tonight's event happen. So thank you. With that, I'll turn it over to Nate, who'll introduce the next speaker.
I'm just going to turn the microphone quickly to Dr.
Hi, everybody. Thank you very much, Dr. Din. On behalf of the North American Skull-Base Society, I would like to welcome you. This is another educational opportunity that is a result of a collaborative effort between multiple societies. This started a few years back between the American Head and Neck Cancer Society and the American Rhinologic Society in collaboration with the North American Skull-Base Society when we started tackling malignancies of the anterior skull base. We realized that we're missing a big aspect of malignancies that impact the skull base if we did not address lateral skull base malignancies. And this is how the idea of this webinar started. So I would like to thank our partner societies, the ANS and the AHNS. I'm here representing the North American Skull-Base Society. If this is a topic that interests you, I invite you to join our annual meeting. I will be heading out to New Orleans tomorrow for our summer course, but our annual meeting is at the end of February 2027 in Nashville, and preceding the annual meeting, there will be a collaborative day on NF2 and vestibular schwannoma in collaboration and co-sponsored by the ANS. So I invite all of you to participate. I would like to thank the panelists. I would like to thank Dr. Din, and I think I pass the mic next to Dr. Shirley Su, representing the American Head and Neck Society tonight.
Okay, everyone. So thank you so much for attending the first Lateral Skull-Base Collaborative. A few years ago, American Head and Neck Society and American Rhinology Society decided that we really wanted to, as otolaryngologists, work across disciplines to improve outcomes for our patients. And that's where the original sort of concept started. And we ran that for 3 years with a lot of great feedback. And so we felt that it was really time to cross the aisle and share their stage with our lateral skull-base colleagues and see how we can, share ideas about in our specialties. So, for example, right now in head and neck surgery, the whole role of immunotherapy and targeted therapy and has really revolutionized the treatment of cutaneous malignancies. And we know that this is a disease that as lateral skull-base surgeons are very intimately involved in. And clinically, I work a lot with my colleague, Dr. Gidley, but it's very rare that we actually have joint webinars. We felt that this would be an interesting and useful concept for both our societies. Thank you so much for American Neurotology Society, Dr. Haynes, Dr. Dean, and Dr. Lindquist for putting this on. Really appreciate your support for this. And thank you so much for the panelists for being here today, and also the attendees for coming on so late in the day after a long day of work. Okay, and I'm going to hand over to Dr. Lindquist.
All righty, so thank you for inviting me to help moderate this session. It's been great to work with the panelists who have done all the heavy lifting here. And and I'm pleased to present our webinar on squamous cell carcinoma of the temporal bone. Temporal bone squamous cell carcinoma is a disease that requires a multidisciplinary treatment approach, and so tonight's panel spans that full care. We have Dr. Nancy Pham, who joins us from Stanford, who's a neuroradiologist. We have Dr. Gidley, who's a neurotologist at MD Anderson here in Houston with me. I'm at Baylor. I didn't mention that, but I'm at Baylor right across the street. Dr. Mark Wax, who's a head and neck and reconstructive surgeon at Oregon Health Sciences University. Dr. Yao Yu, who is a radiation oncologist at Memorial Sloan Kettering. Dr. Neil Akave, who's a medical oncologist at MD Anderson. And Dr. Nicholas Deeb, who's a neurotologist at Mayo Clinic, Arizona. So I'll start us off with a framework on diagnosis and staging, and then we'll go into there from the panelists itself. So I'll go ahead and lay the groundwork here. And temporal bone malignancy is a relatively heterogeneous group of diseases that kind of converge on a common anatomic region. So you have parotid salivary tumors, auricular and periauricular skin cancers, skull-base tumors, and then you have primary temporal bone malignancies of the external auditory canal, the middle ear, and the mastoid. And then, of course, you have metastases as well. And so figuring out, where the disease is located and where it comes from is important because parotid and periauricular skin malignancies tend to be, a large portion of these diseases. The external ear, the external auditory canal have a fair amount as well. And then as you get towards the more rare diseases, the primary temporal bone cancers and the skull-base malignancies. And this is important because the survival depends a lot on where those tumors originate, how early they're detected, how treatment progresses, and from there. So it's really kind of about not just the anatomic areas, but figuring out the histopathology and what's going on there. So when you look at temporal bone malignancy and you talk about temporal bone squamous cell carcinoma, the major groups here come from different areas. And so you have periauricular and auricular skin cancers or cutaneous squamous cell carcinoma. And that's relatively common. The majority of skin cancer for squamous cell occurs in the head and neck, and it's relatively common, 2,100 cases per million population per year. And it's staged with the AJCC guidelines for cutaneous squamous cell carcinoma. You also have a different type of squamous cell carcinoma, which is the primary temporal bone malignancy. So this can arise from the EAC, the middle ear, or the mastoid, and it's much rarer. There's 1 to 2 cases per million population per year, or in total 0.2% of all head and neck malignancies. And this has a separate staging system based on its location, and the diagnosis and the distinction between these is important not just for staging, but also for treatment planning as well. In terms of risk factors, this is a very interesting thing to look at the risk factors because, up to 43% of patients with primary temporal bone squamous cell carcinoma have had a history of chronic serous otitis media or cholesteatoma, otorrhea, or just chronic draining ears. Prior radiation is a risk factor. So nasopharyngeal carcinoma patients who have been treated with radiation therapy show temporal bone malignancy rates over, up to 1,000 times the general population. Of course, for cutaneous malignancy, sun exposure is a clear driver with chronic UV exposure. Less so for primary temporal bone squamous cell carcinoma. And HPV has been identified in a subset of cases, but really the causal role here is still under investigation. And unlike a lot of the head and neck cancers, tobacco and alcohol are not established risk factors. In terms of symptoms, benign and malignant disease can often present with similar symptoms. So you can have otorrhea, otalgia, hearing loss. When you start getting to other types of symptoms like facial nerve dysfunction or parotid masses, of course, that kind of shifts your differential to more of a malignant cause. But, a lot of these things should be able to be treated with, oral hygiene, toilet, topical antibiotics, and debridement. And if things don't get better, that's when you really start thinking about maybe a more malignant cause here. And so this figure on the right shows a few different types of malignancy. The top left, you see a friable ulcerated lesion that was ultimately determined to be squamous cell carcinoma. The top right, you see kind of a rolled edges basal cell. And then the bottom left, you see an adenoid cystic, which is sometimes subcutaneous before it gets much larger. And then melanoma in the ear canal in the bottom right, which can often be amelanotic. So all these things need to be on your differential when the benign disease does not respond like it normally should. And then the anatomy is important as well. So this really helps with a lot of the staging here because these boundaries are what the staging systems are built on. So you have at least for primary temporal bone squamous cell carcinoma, you have the EAC is kind of one of the major foundations of the staging system. And then from there, you can have a superior spread through the tegmen. Inferiorly, you can go into adjacent structures in the neck and the parotid, as well as the jugular foramen. Anteriorly, you have the fissures of Santorini, which are the defects in the cartilaginous ear canal that allow spread anteriorly. You also have the foramen of Huschke, which can be sometimes a remnant from development more in the anterior bony canal. And of course, those things can then proceed to the cartilaginous EAC, the parotid, and the TMJ as well. Posteriorly, there's the mastoid air cells. And then medially, you have the eardrum, you have the middle ear, you have the facial nerve, the carotid canal, and the different foramina there. For primary temporal bone squamous cell carcinoma, we use the modified Pittsburgh T staging system. This is a system developed originally and then modified by Drs. Arriaga and Dr. Moody. T1's malignancy is limited to the external auditory canal with no bony erosion or soft tissue involvement. Then from there, T2 has a limited but not full thickness bony erosion or less than 5 millimeters of soft tissue involvement. T3 disease is more full thickness bone and soft tissue involvement that's more extensive or extension to the middle ear or mastoid. And then T4 disease is more than 5 millimeters of soft tissue involvement, facial nerve paralysis or paralysis, erosion of the medial wall of the middle ear, cochlea, petrous apex, the jugular foramen, the dura, the TMJ, or the stylomastoid foramen. An important modification that was suggested in 2014 was by Dr. Mazzoni, who recommended that patients with anterior soft tissue extension more than 5 millimeters were actually more closely a T3B type category just because of the ease, or relatively ease, I should say, of resection in that area, the spread in that direction carries a better prognosis due to the ability to get a margin around it than posterior, medial, or inferior extension. And the staging system relies heavily on the T stage, showing that this is the primary determinant of a lot of the outcomes for these patients. So T1 disease is stage 1, T2 is stage 2, T3 is stage 3, and then T4 is stage 4. But the important discriminator here is that any nodal disease automatically upstages the disease to stage 4, just given the relatively poor prognosis associated with that. In terms of cutaneous squamous cell carcinoma, we have the AJCC 8th guidelines, which we're familiar with, so I won't go too much into that, but it's basically size and then a lot of the erosion here. So T3 has minor bone erosion, perineural invasion or deep invasion beyond the subcutaneous skin layer, and then a lot of tumors that involve the temporal bone would be more extensive cortical or medullary bone involvement, invasion of the base of skull, or any of the nerves there would automatically upstage it. And here, the staging system involves the lymph nodes that we're generally more, or the N and M status that we're usually more familiar with based on cutaneous squamous cell carcinoma. In general, this has been a disease that has been addressed surgically first with T1 and T2 early stage, generally treated with surgery with a goal of negative margins, just because that's one of the major predictors of outcomes and survival. And then adjuvant therapy is recommended in situations that the pathology dictates. So this is often with the lateral temporal bone, with or without postoperative radiotherapy. And then T3 or T4 disease, so relatively more advanced disease, usually the subtotal temporal bone or the total temporal bone with a parotidectomy and neck dissection, and then often with postoperative radiation therapy with or without chemotherapy. And because it's more difficult to get margins here, and the disease is more advanced, the prognosis is poorer. Relative contraindications would be carotid involvement, petrous apex involvement, jugular bulb involvement, temporal lobe, extensive dural involvement, and we'll go from there and discuss those things a little bit more. One thing that has been suggested, it's kind of a different treatment paradigm, has been definitive chemoradiotherapy as a first-line treatment for advanced disease. And so there's a group in Japan that is, with 34 patients who had T4 disease, showed that, concomitant chemoradiotherapy, even with a relatively high toxicity here with the TPF, they do have a good overall survival up to 5 years out. More recently, neoadjuvant therapy, so induction chemotherapy, or even immunotherapy, which is something that really is emerging, like it is for a lot of the cutaneous malignancies, has also found some data recently in the temporal bone literature as well, and so that will be interesting over time. A really nice meta-analysis looking at the overall survival for these patients based on their T classification showed that overall T1 and T2 disease had a relatively good overall survival, 82% approximately, and then surgery with adjuvant treatment and radiation alone didn't have any significant difference, although I would say that surgery is probably better for postoperative morbidity in terms of radiation, osteonecrosis and things like that. T3 and T4 disease, the 5-year overall survival is relatively poor. And interestingly, in this meta-analysis, there was not a whole lot of difference noted between overall survival for different modalities, including surgery followed by either chemoradiation or surgery and radiation or definitive chemoradiotherapy. So something that, really the T stage does dictate here. And overall, the overall survival for these advanced diseases is still very poor. This kind of speaks to the necessity of needing a multidisciplinary approach to these patients. So it's my pleasure to give the floor over to Dr. Nancy Pham, who's a assistant professor in the Department of Radiology and Neurointerventional Neuroimaging at Stanford, to talk a little bit about the radiographic implications of temporal bone cancer.
Yeah, thank you so much for the introduction and for the opportunity to present on imaging of the temporal bone squamous cell carcinoma. It's certainly a very exciting topic for us. So to start, the goals of this presentation are to review the combined role of CT and MRI for staging. And then we're going to discuss the use of PET-CT in selected cases. And at the very end, we're going to go over 3 cases just to showcase the various patterns of tumor involvement. So imaging supports staging by answering 5 important questions. First, it characterizes the primary tumor. But beyond the tumor itself, it maps out the osseous and soft tissue involvement. And I think a very critical role of imaging, and as a neuroradiologist, is that we try to identify perineural spread because it's important for our surgeons, our med-onc, and our radiation oncologists to understand the proximal extent of disease and how to control that. And then finally, we use imaging to capture nodal disease and distant metastasis in high-risk patients. So as we all know, CT is superior for cortical bone anatomy and erosion. And I think Dr. Lindquist showed a very nice diagram of important structures that we should identify, including the skull base foramina, carotid, and jugular canal. In comparison, MR is superior for soft tissue extension. And I think it's very important to evaluate the intracranial compartment because it's so close to the temporal bone. And then we already looked at the importance of the facial nerve in the staging system. And then in terms of PET-CT, at least at our place, we use it for high-risk patients, and that is defined by advanced local disease at T3 or T4. If there is a suspicion for parotid and cervical nodes, and it's not uncommon for our patient population to present with one or more primary cancers. And so in that setting, we also like to get a PET-CT. So this is our pre-treatment imaging algorithm. For those who could tolerate it, we recommend getting a high-resolution temporal bone CT that is complemented by a high spatial resolution MRI with contrast. It's usually at this time where we add on the neck for complete staging. And then if we think that the patient is going to be high risk based on these initial images, we also get a PET CT at a later point. And as mentioned before, this is a rare cancer in a rare location. And so all of these cases are presented at tumor board, and then we reach a final consensus on what to do. So here are just some reminders about the CT temporal bone. It's recommended that we get less than 1 millimeter slices so that we can completely evaluate the temporal bone anatomy. For those patients who cannot tolerate MRI for some reason, we can add on a contrast-enhanced neck CT at this time point. For MRI, we suggest that there should be several dedicated sequences that have a small field of view, and that will be important for evaluating the external auditory canal, the middle ear cavity, but also to look for very subtle peridural enhancement. And with regards to the PET CT, again, I think I'm just reinforcing this idea that at our institution, we get it for high-risk patients. And I think it's also important to recognize that the PET CT should not replace the high-res CT for the temporal bone because they serve very different function. And then things that are, FDG avid on PET CT, we have a very low threshold to sample them because the management is so important if there is identification of distant disease. So with that foundation, I'm going to go over 3 cases that highlight some of the principles that I've mentioned. So this patient here is a 75-year-old man presenting with right ear pain. So shown on the left is a coronal image, and on the right is an axial image. I labeled some landmarks. So here you can see that there is a mass occupying the entire external auditory canal. And we can see inferiorly that we are concerned about inferior extension into the parotid based on the soft tissue window that I didn't show here, but we'll take a look at the MRI. In terms of the medial extent, we can see that it extends all the way up to tympanic membrane, but we don't really see it extending into the middle ear cavity here. On the axial image, there's bulging of the tympanic membrane, and then looking at the TMJ, we do see that there's some erosion, and so we're concerned that there's extension of disease into that joint. So here's the MRI. So certainly CT could hide a lot of tumor. So I think that's why CT and MRI is they're complementary. So here we see a very large mass extending from the skull base all the way down to the parotid space, infratemporal fossa. It's cystic in some components, and then heterogeneous T2 signal. And so from here, we're going to look at the top of the mass and then go all the way down to the parotid space. So starting at the very top, we can see abnormal enhancement of the periauricular soft tissue. As we go down, we see involvement of that TMJ as suggested on the CT, but there's more to that. The tumor also extends into the masticator space. And furthermore, it also encases the V3 segment in the infratemporal fossa. As we get to the mid-parotid level, we can see extensive extension into the parapharyngeal space, masticator space. There is encasement of the carotid space with the carotid artery there. In the back of the mandible, we're always concerned about the auriculotemporal nerve coursing back there. And certainly we're concerned about the facial nerve, given that the tumor is abutting or actually extending into the stylomastic foramen. And back here, we see hypoglossal canal enhancement. So as we go down further, we see extensive infiltration of the deep spaces of the neck. And this takes us down all the way to the right upper neck, where we see abnormal nodes in the right parotid gland, as well as a couple asymmetric nodes on the right side of the neck at level 2. So we're certainly concerned about nodal involvement here. This is just a T2 showing the parotid node and some of the T2 signal associated with the primary mass. Because the patient was at high risk, we did get a PET CT, and good for the patient, they did not have distant metastasis. So this takes us to our second case. So this is a 65-year-old female with right ear drainage. In comparison to the first case, the thing that we see that's different here is that there's extension into the middle ear and that there's tumor crawling up Prusac space. On the axial image here, in the middle panel, I just wanted to show that there's remodeling of that anterior EAC wall. And this mass was, of course, FDG avid. On MRI, I'm showing the T1 without fat suppression because I think this is a good sequence to try to get the lay of the land, because the tumor itself is usually isointense to brain and then the adjacent muscles. So when you lose the fat planes, it's obvious, it's very obvious when you're looking at a T1. So here's the T1 isointense tumor in the EAC. Inferiorly, it's extending down to the superior margin of the parotid. This is demonstrated again on the axial images. After we give contrast, there's heterogeneous enhancement of the mass in the EAC, and then it looks like it also extends into the middle ear canal. And then again, that, there's some blurring of that superior margin along that parotid, and that will be important. So this is a coronal image of the temporal bone after a resection, and here's an axial image with reconstruction there. So I pointed to that inferior region, that superior margin of the parotid, because it's going to be relevant for this case. So on surveillance imaging, a couple months later, there's this area of abnormal signal. As we look on the axial images, there's just this intermediate kind of gray stuff in the bottom of the resection bed. So we're certainly concerned. When we look at the post-contrast imaging on that at that location, there's intermediate enhancement. And this is really worrisome for us because in the post-operative period, inflammatory or granulation tissue, it takes up a lot of contrast. So it's usually hyperenhancing. Anything that is in the intermediate range like this kind of gray shade, when you have contrast on board, is very concerning for tumor. So here, where we're concerned about a recurrent, this patient also has an incidental vestibular schwannoma. Here's a T1 of the same location, outline the boundaries of the recurrence. And at our shop, we also do advanced imaging. It's not necessary, but certainly helpful. So this mass demonstrated restricted diffusion on DWI, indicating high cellularity, and hyperperfusion on our ASOL sequence. Because of the recurrence, the patient also got a PET CT, and on the CT, there was no distant metastasis. And then I'm going to end with this final case. So this patient is a 60-year-old male presented with right ear pain and headache. The top panel are all coronal images, and then the bottom panel is all axial images. They demonstrate a enhancing mass in the EAC. On the bone window, we're concerned about middle ear involvement just because that Prusac space appears infiltrated. And then again, the inferior margin of the EAC appears eroded. On axial images, there's extension into the TMJ with associated erosion of the anterior wall of the EAC. But we can see much more on the MRI. So if we just take a global look at the coronal image here, we can see that there's dural involvement, violation of the tegmen, big EAC, middle ear mass, and then it also infiltrates all the way down to the superior margin of the parotid. So for this case, I'm going to start at the bottom and go up. So at the level of the inferior parotid gland, we see an infiltrating mass. there is, this ill-defined enhancement along the mandible. So we're concerned about auriculotemporal nerve involvement. As we go up, we see that enhancement extends into the EAC, TMJ, the middle ear cavity. And then up, we see involvement of the temporal bone as well as the dura. I think some things that I want to point out here is when we see this ill-defined enhancement tracking along the scalp, we get concerned about pyramidal spread along the temporal and zygomatic arch of the facial nerve. And here we can see thickened and abnormal dura, which is consistent with dural involvement, as opposed to imaging findings that would support reactive dural enhancement, which is more likely to be smooth rather than this nodular thickened appearance. Again, we do our advanced sequences showing hyperperfusion and restricted diffusion, indicative of a cellular mass. And then distant staging did not reveal any distant disease. And so with that, I just want to summarize that, CT and MRI are both important for staging. In terms of the PET-CT, we obtain it in high-risk patients as we've defined previously. And with that, I thank you for your attention and time, and I'll pass it back to Dr. Lindquist to introduce our next speaker.
Alrighty, so it's my pleasure to introduce Dr. Paul Gidley from MD Anderson, who will be discussing surgical options for this disease.
Thank you for that introduction, and then I will share my slides. We will talk about surgical management. These are my disclosures. Nate already presented this graphic to you. I want to highlight the difference in survival between ear canal cancer, preauricular skin cancer, and temporal bone cancers. All three sites are squamous cell cancers, but cancers that are confined to the ear canal, they tend to do very, very well. Temporal bone cancers do very poorly historically. And then periauricular skin cancers are nasty players. When they involve the temporal bone, they typically are recurrent and previously treated, and they're notoriously bad players. Nate has already discussed this. I use the Pittsburgh staging system for planning surgery. So tumors that are confined to the ear canal are resected very nicely by en-bloc lateral temporal bone resection. Parotidectomy, neck dissection, and reconstruction are added as needed. T3 tumors that involve the middle ear, I use a subtotal temporal bone resection. And when I say subtotal, I'm talking about an en-bloc lateral temporal bone with piecemeal subtotal resection. And then T4 tumors that involve the inner ear get a total temporal bone resection. The goal of surgery needs to be clearly understood and defined, and the goal is to achieve a negative margin. We have to protect critical vascular structures such as the carotid artery. Sigmoid sinus and jugular vein can often be sacrificed without too much collateral damage. We need to be mindful of critical nervous structures, but unfortunately, sometimes facial nerve, hearing, and balance get destroyed in order to get rid of the cancer. Now, I want to present this patient with a recurrent squamous cell cancer of his outer ear. And I want to highlight the fact that it's involving his meatus, his cartilaginous ear canal. And as you can see from this endoscopic photo, further into his ear canal, it does not involve his bony canal. This is an important distinction. Tumors that involve the membranous canal can be excised with a wide local excision, excising the underlying cartilage, and checking the medial or canal margin. This is the most important margin from my standpoint. If the tumor involves the medial canal, you need to be considering a lateral temporal bone resection. If, on the other hand, if all of your margins are negative, then reconstruction with a skin graft does quite well. Let's move on to cancers involving the ear canal primarily. So this is a squamous cell cancer. You can see it here in his left ear canal. The imaging shows that it does not violate the bone or penetrate into the middle ear. PET imaging does not show any distant disease or other spread of disease. And so for a patient like this, the surgical approach is a lateral temporal bone resection. I like to do parotidectomy, or I should say I have my head and neck colleagues do a parotidectomy in level 2 neck dissection for staging. We use a pre-auricular type of incision as demonstrated here. This gives great access for the parotid and neck as well as for the temporal bone. You can even implant an OSSEA device through such an incision. And for this presentation, I don't have enough time to go into a lateral temporal bone resection. There's a very nice video on C surgeries that shows our technique. But his pathology returned as favorable for him. No negative, or I should say, no adverse pathologic findings, no lymph nodes, so forth. And he's doing quite well with his OSSEA device. Now, let's move on to larger tumors. Dr. Pham has already shown us the key radiologic landmarks. Here's a man who presents to us with ear canal cancer. You can see his otoscopic view here. He has facial paralysis. He has T4 disease. His imaging shows that he has disease that penetrates through the entire temporal bone down to the level of the dura. It also extends along the jugular foramen into the upper neck. So for this patient, we decided to treat him with upfront chemotherapy, carboplatin, paclitaxel for 1 cycle, and he got a partial response. We then proceeded to lateral temporal bone resection with a jugular foramen dissection, parotidectomy, neck dissection, ALT free flap. His pathology report shows extensive disease involving the mastoid, the parotid, facial nerve, and jugular bulb. But you will notice that the pathology report indicates that this is devitalized squamous cell carcinoma. So his upfront chemotherapy definitely had an effect. He received postoperative concurrent chemoradiation, and here he is, he's 20 years NED. So clearly a success story. It brings up the subject of facial nerve sacrifice. Now, in his case, he presented with facial nerve paralysis, so that's not a difficult decision to make. But when a patient presents with normal facial function, it becomes very difficult. As you can see in this photograph here, once the facial nerve is decompressed, the mastoid tip is removed, you get a better view of the facial nerve. This happens to be a parotid tumor that is ascending up into the facial nerve. And so this tumor is biopsied. If it returns as cancer, then the decision to sacrifice the facial nerve is very easy to make. And in our larger population of nearly 600 cancer patients involving the temporal bone, 45% of them required facial nerve sacrifice, and we do nerve graft whenever possible. As a continuation is how far do you follow the facial nerve? Well, we studied our own patients. We had 13 patients that had a positive proximal margin. None of those patients recurred along the proximal facial nerve. And by understanding this is there's no need to do labyrinthectomy to chase a microscopic margin into the IAC. You're talking about microscopic disease that can be treated with radiation therapy. Furthermore, this positive margin doesn't interfere with facial nerve grafting. Dr. Wax and Cayley did a very nice paper looking at that very question many years ago. Now, let me present this patient. This is a man who had chronic otitis media since childhood. He had a canal wall down, mastoidectomy, chronic drainage. He then developed swelling in his parotid gland. A biopsy was performed showing squamous cell cancer. He presented to us with facial weakness just beginning. You can see his imaging study here. He had very extensive disease. We also use CT and MRI, as Dr. Pham pointed out. You can see he's got disease that's filling his temporal bone mastoid cavity. It's extending into the preauricular skin. It extends medially to his carotid artery. It extends superiorly up to the dura. So very extensive disease. At our multidisciplinary tumor board, we decided to give him cemiplimab up front. He got some symptomatic improvement with decreased pain, and he felt his swelling improved. He also felt his facial weakness was improving. This is his PET-CT. He still has a significant amount of metabolic activity from his tumor, so we decided to proceed on with surgery. I performed a subtotal temporal bone resection. My neurosurgery colleague came in and resected the dura. Head and neck surgery came in to do parotidectomy and neck dissection, and plastic surgeons did an ALT free flap. He had also extensive disease on pathology, so we followed up with concurrent chemoradiation therapy, and here he is. He's now about 2 years out from treatment and NED. There are limits to resection. So I present this gentleman here, 87 years old. He has squamous cell cancer involving his middle ear. You can see it has completely replaced his temporal bone. It's extending inferiorly into paraspinous muscles. So from that standpoint, he is not a surgical candidate. This gentleman had lots of ear surgery on the outside. He then presented to us for further management, and you can see he has these subcutaneous nodules. These nodules are dermal metastasis, which is essentially like distant metastasis, so he is not a candidate for surgery. And then you see this relatively innocuous looking ear canal, but ends as a blind sac. Her imaging shows cancer that has completely replaced her temporal bone and surrounding her carotid artery. She is not a candidate for surgery either. Now, I want to switch gears and present a periauricular skin cancer. This is a gentleman who presented to us with this large bleeding ulcer. He comes in with this white powder on him. I had never seen this before. What is that? It is bleed stop. And some of you may be familiar with this. I had never heard of it. It's something available over the counter for bleeding, and he had been pouring that into his wound to stop it from bleeding. We did imaging for staging, and you can see he has extensive disease involving his temporal bone and all of the periauricular skin. We did a staging PET-CT, and he has no distant disease. So given that it was a cutaneous tumor, we were considering immunotherapy. But on a Friday afternoon, he presents to us with severe bleeding. And so our interventional colleagues took him and did embolization of his postauricular artery and occipital artery. From there, he was able to start his immunotherapy, got 3 cycles of cemiplimab with a partial response. We then decided to follow up with concurrent chemoradiation therapy. And this is him about 6 weeks following that treatment, and his massive ulcerated bleeding tumor is completely gone. Unbelievable. I couldn't believe it when I saw him. And here he is. He's now more than 2.5 years out from treatment, completely NED, which shows the power of combined modalities for treatment of these extensive cutaneous periauricular skin cancers. Survival outcomes for early stage tumors are still very, very good, but T3 and especially T4 tumors, we have a long way to go. When patients present with node-positive disease, their survival outcomes are much worse than node-negative disease. So, just as a conclusion, the goals of surgery need to be outlined and be specific. The intent should be to achieve a negative surgical margin. It takes a village. So this is definitely a team sport involving neurotology, head and neck, plastic surgery, neurosurgery when the dura, sigmoid sinus, jugular foramen are involved. tumor histology, lymph node metastasis, advanced stage are indicators of aggressive disease. And so you need to be thinking not only about postoperative radiation, maybe chemotherapy, but also to consider neoadjuvant chemotherapy or immunotherapy for advanced stage disease. So thank you very much. And I turn it over to you, Nate.
All righty, thank you for that. It's my pleasure to invite Dr. Mark Wax, who's a professor at OHSU, to discuss management of the neck and reconstructive options.
Okay, I'm going to utilize the skill set of Nate to advance my slides. If you want to share, sort of 89 on your group. I have nothing to disclose. This is our Hood to Coast team. Anybody that wants to come out and run from the top of Mount Hood down to the ocean is welcome to contact me, and we would love to have you there. Next slide. I think the overriding message that you've heard is that this is a multidisciplinary approach and a multidisciplinary treatment and disease. I had the benefit of having seen many of the speaker slides, and so my talk is going to be rather shortened, and I'm not just going to repeat a lot of what other people have said, except to emphasize that it is a team. It does take a village to treat this particular disease. I'm going to discuss the ablation for the skin margins, the parotid, the neck, and then finally the reconstruction ranging from local flaps up to free flaps. So next slide. So the approach to the skin, when you have these large tumors, when they're either invading out into the skin from the parotid, or they've started out as a skin tumor and they've invaded deep into the parotid and then into the lateral temporal bone, it's a simple, go big, go home. I think other speakers have emphasized that negative margins are the key to this. If you're going to have a reconstructive surgeon, then don't worry about the reconstruction. Take as big a margin as you can to get that negative margin. The reconstructive surgeons, here's hubris. You make a hole, we can fix it. And we can usually do a pretty good job depending on what the composite tissues are, and I'll discuss that just a little bit later. And no matter how ugly it looks after the reconstruction is a work in progress, both between the reconstructive surgeon or the facial plastic surgeons or the plastic surgeons. They can oftentimes take what is a rather, it works, but it may not be the most pretty reconstruction, and over time tailor it down until you have a significant and a quite acceptable cosmetic outcome. The question as to the approach for the skin for negative margins is whether or not you want to utilize the Mohs surgeon. And oftentimes we will have the Mohs surgeons map out the margins of the tumor. So the patient comes in, the Mohs surgeons does this on a Monday, they give us our results on Tuesday, and then we proceed with them having drawn a line around where the lateral margins or the skin margin is going to be to facilitate what it is in taking out the rest of the tumor. One advantage of the Mohs surgeons, I'm not sure what everybody's operating room time and schedules are, but if you have the patient get their Mohs surgery, you get them admitted to the hospital, rarely do you get a phone call that says surgery is busy, no ICU beds, etc. We're going to have to cancel your case. They do that for outpatients. Rarely do they do it for inpatients. So next slide. So what about the parotid? I have a very select bias. Most of the tumors that see us or that get to us are large, extensive, they're multidisciplinary, and they involve more than just that little external canal that Dr. Gidley showed a beautiful example of. So rarely, if it's just a canal tumor, are we involved? If it's just a conical bowl, rarely, do they need much more than that. The skin, I think we talked about the skin involvement and how you manage the skin. The tail of the parotid, again, depends. The parotid, it depends on what the extent of the skin involvement is. There isn't a lot of literature for temporal bone tumors involving the parotid, and most of the management of the parotid depends on what you're going to do with the facial nerve and what you're going to do from a reconstructive perspective. So oftentimes the tail of the parotid gets resected, coming down. The facial nerve gets identified, coming to identify the stylomastoid foramen and follow it so you can do your lateral temporal bone. And resection of the parotid, once you've identified the facial nerve, is merely an anatomic dissection to facilitate resection of the tumor and to facilitate the reconstruction. The role of immunotherapy is tremendously exciting. We have seen skin cancers that looked like that one I showed originally, and they just completely disappear. And there isn't a lot of literature on that. In this particular disease entity, it's probably something we can start to think about and people are using for the skin cancers that extend medially. So let's go to the next slide. The neck, again, rarely is the neck involved. There's not a lot of literature for the lateral temporal bone lesions, but mainly if you have an N-positive neck, then your institution probably has a paradigm approach for doing a connect dissection as to what levels. If you have an N0 neck, then you can really pick your side. There's literature that supports either doing nothing because you're going to get chemoradiation afterwards, or there's literature that supports doing an N2, N3 for staging. At the end of the day, at our institution, most of these large tumors get a level 2, 3. It adds about 15, 20 minutes onto the operation. It gives you sampling node data. And if you're going to be doing a free flap for reconstruction, then it facilitates identification of the vessels. Next slide. From I'm not going to talk about this temporal bone. Facial nerve we've touched on, but that I think is a topic in itself. Gracilis flaps and facial nerve reconstruction, I really won't talk much on, only just to say that if you do sacrifice the facial nerve, rehabilitate them at the same time. It is a world of difference between rehabilitating the facial nerve, fixing the eye. So here you've just got two examples where this one fellow has not been fixed. He's going to get fixed, but oftentimes from scheduling for a multitude of factors, that can take weeks, months. And the other fellow on the right-hand side, he had all of his facial nerve rehabilitation done during his primary surgery. He can close his eye. He's got a little bit, he doesn't have as much facial droop. Cosmetically and functionally and psychologically, they do tremendously better if you can rehabilitate them at the same sitting. So next slide. Reconstruction, best topic ever. We don't do a lot of local small flaps. They're usually done by the neurotologists. The key with reconstruction is you need volume, you need composite tissue, and you need to be able to obliterate that dead space. Next slide. It ranges from, this is a temporal parietal flap. You can see you got great vascularized tissue, but not a significant amount of tissue volume. On the right-hand side, this would be a fat graft if you were going to do this. Next slide. Local flaps that have been discussed are the submental island or a propeller or supraclavicular flap. Technically, they're relatively easy. The volume of what the defect is seems to be the biggest issue. And although there are a number of centers that utilize these flaps or local flaps in a lot of their patients, it just seems to be whatever the local environment is. New paragraph, I'm dictating. Next slide. Free flaps. So free tissue transfer for reconstruction of these particular defects is one of the easiest flaps that we do as reconstructive surgeons. It's fast. Usually by the time the ablative surgeon and the neurotologist have got finished, it's 2, 3 o'clock in the afternoon. It usually takes us a couple hours to do something like this. It is also the poorest paying and reimbursable of what we do, since it does not have a lot of codes that go with it, but it's a relatively simple procedure. Next slide. It's a volume issue. Depending on what the volume of your defect is, we try and fix the same volume with what the volume of the defect. So I have to give credit to Evan Rosenthal from out at Vanderbilt, to many of my fellows who have helped to develop, sort of what our paradigm is. If it's a low volume flap, then the radial forearm flap up at the top gives you some good subcutaneous tissue, some skin. If it's a high volume, you start to range from an ALT flap down at the bottom left, and on the right hand side, a latissimus dorsi flap, which gives you massive volume to fill in and obliterate. Next slide. So I put this here just to say that it's the dead space that kills our flaps, and it's the dead space that gives you your wound healing issues. On the left, you've got, make sure I'm doing the right one here. On the left, you've got a glass. It's full of toilet. It's full of Kleenex. And you can see how that when you compress it in there, there aren't a lot of gaps. There's not a lot of dead space. And the Kleenex, if you were putting that into a mastoid cavity, or if you were putting it into a complex defect, would fill in all of that dead space. Whereas on the right-hand side, that is paper towel. And when you put it in, you can see there's lots of gaps, lots of air. It's not going to stick into tall, tiny places. So depending on what your defect is, you're going to want to be able to tailor your reconstruction to fit and fix, where the hole is. Next slide. You want vascularity. If you need good vascularity, then you're looking at, muscle, because it's going to fit into all the little nooks and crannies. It's got a great blood supply. If they've got radiation coming up. Next slide. So, the multidisciplinary nature here is what we strive for. The ablative surgeon is your friend. You need a parotidectomy done. You probably got the exposure. They are more than happy. Come in, take out the parotid, they go home. If they got to do a little bit of a neck dissection, they're more than happy to come in and help you with that. The reconstructive surgeon is also, your friend. They're more than happy to come in and do this and rehabilitate the facial nerve. That was it for my part. So thank you all very much.
Where do Q-tips fit in your dead space obliteration, since we're otologists?
They are the best because they jam that wax right in there. And then I can send the patient off to Dr. Gidley to fix it.
All right. Well, no arguing there. Next, we'll have Dr. Akave, who's a medical oncologist at MD Anderson. Looking forward to hearing what he has to say.
Thank you again. I will also lean on Dr. Lindquist to advance my slides. I'll be talking about the role of the medical oncologist in local regional therapy for temporal bone squamous cell carcinoma. Next slide. As with Dr. Gidley, I think we need to understand our rationale for each treatment. I'll reinforce the same point. Why do we use, what is the rationale for systemic therapy in local regional disease? I break it down in these two different ways. The rationale, although we still are working to define this in temporal bone squamous cell carcinoma of neoadjuvant systemic therapy, is number one, to decrease the burden and morbidity of surgery. Of course, these surgeries, although I'm not a surgeon, are morbid. They're difficult for patients. And the use of systemic therapy to try to reduce that burden is certainly valid. And then based upon pathologic features, can we clarify prognosis and therefore optimize subsequent adjuvant therapy? On the right-hand side, I talk about the rationale for adjuvant systemic therapy, either alone or in conjunction with radiation. This is really to improve disease control outcomes for folks that we define as, quote, high risk. And we have to continue to work towards defining what that high risk is. Is it the same as with other areas of mucosal head and neck squamous cell carcinoma, or are there other additional risk factors? As we move to the next slide. I think as we've again hammered home during the course of this webinar, there's a real critical distinction here with regards to diseases, squamous cell carcinomas that are cutaneous squamous cell carcinoma-like, or the rest of mucosal squamous cell carcinoma-like that comes with distinct staging mechanisms, route to the temporal bone. It also, from a medical oncologist standpoint, speaks to distinctions, even speaking to the underlying genomics and the tumor mutation burden. With regards to tumor mutation burden, this is measured usually under the methodology of mutations per megabase. Primary temporal bone squamous cell carcinomas usually have a tumor mutation burden that's less than 10 mutations per megabase. In contrast, cutaneous squamous cell carcinomas, really that occur anywhere, usually have a tumor mutation burden of greater than 10 mutations per megabase. Really, why does that matter? Mutations per megabase in and of themselves speak to the potential for having neoantigens that are expressed on the cellular surface that then have the potential to be immunogenic, that can speak to response rates to immunotherapy. This is why cutaneous squamous cell carcinomas are so responsive to PD-1 inhibitors or PD-L1 inhibitors, independent of PD-L1 expression. The indication is independent of that. There's also a pan-tumor indication for immunotherapy with pembrolizumab, with a tumor mutation burden greater than 10 mutations per megabase, sort of hammering that same point home. With regards to key mutations, actually genomically, the overall type of mutations are similar between mucosal squamous cell carcinomas and cutaneous squamous cell carcinomas. You see 9p21 loss, which is reflected by CDKN2A and CDKN2B loss across the board. You see Notch1 or p53 mutations universally. The real difference here is the number. Ultimately, we just see a lot more mutations. They're not any more actionable in cutaneous versus temporal bone squamous cell carcinoma. They just are more in number. Again, why is this really important? It really reinforces the distinct tumor biology, epidemiology between cutaneous-like versus temporal bone, sort of mucosal-like squamous cell carcinomas that can predict for differential responses to systemic therapy, particularly checkpoint inhibitors. And cutaneous biology and its response is really driven by tumor mutation burden and neoantigen expression. And if we can obtain a PD-L1, a mucosal biology response is maybe more driven by that than TMB. What are the implications of this, as we'll talk to my eventual take-home points? If there's equipoise, a biopsy, and that's of course challenging. Paul and I have shared a few cases where that can be really challenging. If the biopsy is sufficient to allow for tissue NGS or PD-L1, that can be really useful to guide the medical oncologist. I will say that a lot of times in many of our institutions, we lean on liquid NGS sometimes in certain diseases. That's of course not helpful here. It may tell you about specific mutations. It does not speak to PD-L1 expression or tumor mutation burden. So we move to the next slide. So what is the real role for systemic therapy? And we'll just start with what is the question of induction chemotherapy. Ultimately, I will say we lean upon our understanding of the use of induction chemotherapy as an extrapolation from other more common tumor types, but there are small limited case series that have demonstrated that induction chemotherapy can be beneficial in temporal bone squamous cell carcinoma. I have highlighted two case series here. One, the first one involved unresectable patients who were going to receive definitive radiation or chemotherapy and radiation. In the setting of induction TPS, amongst 10 patients, there was an improvement in overall survival and disease-free survival, in contrast to 4 patients who did not get induction chemotherapy and got radiation or chemoradiation and had very poor outcomes. But of course, that's only 4 patients. Similarly, the Tata Memorial Group has talked about the conversion of patients who were unresectable with platinum and taxane to resectable in 8 out of 12 patients. So again, speaking to the benefits of potentially converting patients from unresectable to resectable disease, although it's unclear if that has an impact on survival. We've of course learned that from the oral tongue world, where induction chemotherapy certainly can reduce the size of a tumor, but did not come with a survival benefit. So ultimately, how we use induction chemotherapy in temporal bone squamous cell carcinoma is primarily in the context of conversion therapy, potentially trying to convert a tumor from very morbidly resectable to less morbidly resectable, or unresectable to resectable. That is possible, however, unclear how it impacts survival, and that needs to be studied further. With regards to the next slide, we'll talk a little bit more, and this, I'm sure Dr. Yu will go into more detail with regards to the considerations of timing of chemoradiation. I'll highlight the meta-analysis by Takanaka et al., which has, I think, also been referenced by Dr. Lindquist here, which seemed to suggest, at least in a hypothesis-generating way, that preoperative chemoradiation may have a better survival. Of course, this was with only 7 patients, and only 7 patients and a single center. So it's really only hypothesis generating. Primarily across most of our institutions, we'd be using primary surgery followed by postoperative radiation/chemoradiation or definitive chemoradiation. Going back to T3 and T4 disease, again, the same. I wish I had the same figure that Nate presented. It was more pretty than my little list here. The meta-analysis of about 1,200 patients with temporal bone squamous cell carcinoma. With regards to 5-year overall survival amongst the comparison between surgery followed by chemoradiation, surgery followed by radiation, or definitive chemoradiation, overall the survival appeared to be equal amongst all those different groups, which suggests that they can be used in a case-by-case basis equivalently from a survival standpoint, although toxicities of surgery and definitive chemoradiation need to be considered. And then finally, what about the role of the radiosensitizer? I will say in current clinical practice, at least in the United States, this is extrapolated from the rest of mucosal squamous cell carcinoma and most commonly involves weekly cisplatin. However, in Japan, certainly the Japanese groups have talked about disease-specific regimens, specifically TPF. Now, TPF, the thought there is that generally the radiation is sparing the mucosa. We can intensify chemoradiation by using TPF. This TPF is a little bit different than the TPF dosing that we would commonly use as a primary systemic therapy in the United States. This would include cisplatin 80 milligrams per meter squared, docetaxel 50 milligrams per meter squared, and then 5-FU 600 milligrams per meter squared day 1 through 4, given every 3 weeks for 2 cycles, versus high-dose cisplatin given every 3 weeks. Again, this high-dose cisplatin was given at a slightly lower dose in this particular paper. This sort of gave us the provocative data that from a PFS and an OS standpoint, amongst 10 patients in each cohort, that concurrent TPF may be beneficial. I will just note the toxicities were significant here. The rate of grade 3 neutropenia, which is not at all a surprise with TPF, was about 40%, and grade 3 mucositis was about 50%. I will note that, at least in historical data, when systemic TPF is used just by itself, the rate of treatment-related mortality, just death from TPF, is about 1%. And so it can be quite an intense regimen. Next slide. What about the role of immunotherapy? I mean, certainly we've talked about this and we've each shared our anecdotes of really impressive responses. This really has been spurred and reflects kind of these 2 papers, at least hinting at in periauricular squamous cell carcinomas that are cutaneous in biology. We can see incredible responses. In the neoadjuvant space, cemiplimab has shown incredible responses in resectable disease. There's no comment on temporal bone involvement, but at least some of these probably did include temporal bone involvement. And response rates are approaching 70 to 80%. Similarly, in the adjuvant phase, after surgery and radiation, giving adjuvant cemiplimab again came with a disease-free survival benefit. And so there is this role for immunotherapy in those who are cutaneous biology. But what about in temporal bone squamous cell carcinoma? And that really goes to the next slide. So Caitlin Brooks Aragon, who happens to be in the audience here, wrote this paper, which is accepted for publication, that summarized the experience of MD Anderson and Baylor and the response rates to immunotherapy in primary temporal bone and cutaneous squamous cell carcinoma. Amongst these 23 patients, of which 12 had cutaneous squamous cell carcinomas and 11 had primary temporal bone squamous cell carcinomas, the overall response rate to cutaneous squamous cell carcinomas was similar to what we would expect in other anatomic sites, about a response rate of approximately 65 to 70%. That's really good. Similarly, in primary temporal bone squamous cell carcinoma, the response rate is just notably less, 36% amongst these 11 patients, so just less. And I think that speaks to differences in biology and epidemiology. That's just notable. Immunotherapy is not that it's not going to be effective. It may not just be as effective. Don't expect as dramatic a response universally as you might be thinking with a tumor that has a past medical history that's clearly cutaneous, lots of actinic exposure, so forth. And then the last few slides. So I guess ultimately, what are my take-home messages here? The role of systemic therapy in lateral skull-based malignancies is limited by the rarity of disease and the lack of randomized data. If available, from a medical oncology standpoint, and it's unclear about what the patient history, NGS can be really helpful to anchor disease biology as cutaneous or mucosal-like, really by the TMB, although notably that does take about 3 weeks to come back. And so that should be accounted for as you plan out your treatments. I would, if it's possible, get a PD-L1 universally, but if this requires a bigger biopsy, that's of course challenging. For cutaneous-like disease, it's very reasonable to consider neoadjuvant cemiplimab for downstaging, or adjuvant cemiplimab to minimize recurrence. For those who have more mucosal-like disease, whether that's defined by history or TMB, I would still involve the multidisciplinary team, consider primary surgery or definitive chemoradiation based upon stage. Although induction chemotherapy and immunotherapy can be considered, and maybe there's a future for chemotherapy and immunotherapy. Response rate, I will note, is likely to be less in cutaneous-like tumors, and so just be aware that your rate of conversion may not be quite as high. And if the tumor is clearly not responding, a patient's more symptomatic, adapting and moving towards surgery will be really important, and having a team in place that can do that quickly will be really helpful. And then the last slide. And then finally, for locally advanced tumors, T3, T4, definitive chemoradiation can be appropriate. The data is mixed about the most appropriate concurrent regimen. I will say that in our center, we use concurrent cisplatin. Concurrent TPF is sort of provocative, but appears to be quite toxic and would really benefit from a prospective trial. And I will say the role of neoadjuvant chemoradiation is limited to a very small number of patients and is primarily hypothesis generating and needs to be reevaluated in the context of our understanding of the role of immunotherapy. And I'll just finally end with some cases, and really just to express caution of instances where immunotherapy may not have worked out so well. And so actually, interestingly enough, both of these patients are shared with the esteemed Dr. Gidley. So the first one is a 68-year-old fair-skinned female with no prior history of non-melanoma skin cancer, presented with progressive hearing loss. Imaging showed T4N0 disease. PD-L1 actually was able to be obtained. It was 2%. We ended up proceeding with neoadjuvant cemiplimab, considering she had what was initially felt to be quite unresectable or morbidly resectable disease. She had stable disease at first restaging after 2 cycles, and so proceeded with concurrent chemotherapy and radiation with weekly cisplatin. She did well for quite some time after that, but unfortunately had a local recurrence after 18 months that required a subtotal temporal bone resection followed by reirradiation. Because we certainly had more tissue at that time, we ordered NGS. The DNA alterations were not really helpful. There was nothing actionable or targetable there. Her TMB was very low, though, 6 mutations per megabase. She unfortunately, again, 6 months later, had an unresectable recurrence. She received carbo, Taxol, pembro, again, extrapolating from the other mucosal squamous cell carcinoma world, which had upfront progression. She did not respond at all, was progressed at first restaging, and she's currently receiving salvage cetuximab, and actually is responding to that, has had a really nice partial response, but only on first restaging. We'll see what the duration of response will be. The second patient I'll note is a 58-year-old dark-skinned female, actually from Turkey, with a past medical history of a high-grade salivary gland cancer, who underwent a parotidectomy followed by adjuvant chemoradiation with high-dose cisplatin. This was complicated by radionecrosis, chondronecrosis of the external auditory canal, which was being monitored serially. After about a 14-year disease-free interval, she developed a squamous cell carcinoma involving the extra-auditory canal. We actually treated her with neoadjuvant cemiplimab on protocol, but she had upfront progression and underwent a subtotal temporal bone resection followed by adjuvant chemoradiation. She's actually done very well from that since that treatment, but notably did have upfront progression. And biologically, this is not a UV-mediated disease. This is more mucosal-like. And so I'll just note these 2 cautions. I think we've certainly seen successes. I'll bring up these anecdotes of cautions.
That's great. Thank you. It's now my pleasure to introduce Dr. Yao Yu, who's a radiation oncologist joining us from Memorial Sloan Kettering.
Thanks so much. I'll count on Dr. Lindquist to help advance my slides as well. So I'm going to talk about radiation therapy for temporal bone carcinoma. We'll talk a little bit about the target delineation, a little bit about sequencing, which Dr. Agave already touched on, and a little bit on protons as well. And I'll present some newer data, which I think is a little bit provocative, but maybe still somewhat preliminary. Next slide, please. I have some funding from EMD Serono and Nerviano. Next slide. So I think this kind of classification has already been touched on. There are the primary temporal bone squamous cell carcinomas, the cutaneous squamous cell carcinomas, which have very different biology, and I think they have different epidemiology too. So the cutaneous patients are usually a little bit older. Their ability to tolerate systemic therapy is a little bit different. And of course, we just heard about their response to immunotherapy. I think many of us have seen dramatic responses to cemiplimab and immunotherapy. I guess the parotid, the primary salivary gland tumors, can also arise in this space a little bit, maybe not quite on topic, but there are multiple histologies. They have many of the same anatomic considerations, but they also have an expanding systemic therapy profile. Next slide. In terms of target volume, so I think the two contexts where we use radiation are in the postoperative setting and definitive chemoradiation. As Dr. Akave mentioned, I haven't really seen a case of neoadjuvant. I think we're often worried about the wound healing after a full dose of chemoradiation, if we need to follow that with surgery. So that's certainly not our institutional preference. I generally like to talk to the surgeons about the extent of facial nerve involvement, how they felt about the margin and the resection. We saw a few cases from Dr. Pham about the auriculotemporal extension. And so even for cases where there's perineural invasion without frank auriculotemp involvement, I usually cover that electively and go up to foramen ovale in order to cover that potential route of spread. I really like MR imaging. We saw many cases where the MR is very elucidating for the extent of perineural invasion and soft tissue involvement. Of course, the CT is very good for the bony involvement. And there's often a question of how much of the facial nerve to cover. And I think this is where it's helpful to talk with the surgeons about how far to go. The doses are relatively standard. These are mostly extrapolated from mucosal sites. So it's 70 gray for gross disease, 60 to 66 for the high-risk bed, close margins or positive margins. Elective dosing is evolved a little bit. Traditionally we do 50 to 54. I often cover the parotid 1B to 3 or 4, depending on the situation. But there's some, recent randomized data suggesting that the elective doses could be dropped safely down to 40 from Europe. For cutaneous squamous cell carcinoma involving the ear, I usually include the postauricular kind of posterior nodal field because that can be a site of failure as well. Next slide. So from a radiation standpoint, this can be kind of a tricky site. There's a lot of critical structures in this area. There's the temporal bone itself, which is often susceptible to osteoradionecrosis, the cochlea, the facial nerve, and then the brainstem, the temporal lobe. I find that it's very difficult to spare the ipsilateral cochlea, and so I usually counsel patients, even if they have intact hearing before, if we're covering close to the cochlea or there's a lot of temporal bone involvement, that there could be some hearing loss, especially with longer-term follow-up. So it's important to evaluate the contralateral ear, assess their hearing, and really try to spare that when designing the radiation. Brainstem is generally restricted at 54 to 60 gray. And I think the temporal lobe, for some of these really advanced cases, the tumor goes right up to the brain, and that's really where we have a lot of challenges because that's a little bit beyond kind of the necrosis threshold for cerebral radiation necrosis. So this is something that we often have to discuss with patients at length. Next slide. I wanted to talk a little bit about protons. This, I think, was traditionally less available at many centers and has increasingly become more available. I think it's a little bit of a double-edged sword, and we have how we use it has evolved. So the argument for protons is generally that there's something called the Bragg peak for charged particles. You can see this with carbon as well, carbon ion, and essentially there's very limited exit dose with protons. So you can take a single beam, aim it at the target, you can control where the beam will end. And for a lateralized site like the temporal bone, this can be very helpful for sparing the brainstem and the brain and all of the critical structures in that area. What we've learned about protons over the last few years is that there is a challenge with the Bragg peak. Right at the edge of the distal end of the Bragg peak, the effect, the radiobiologic effect of the protons actually increases. And so this can lead to unexpected toxicities if you're aiming the distal edge right at a really critical structure like the brainstem or the optic apparatus. So what we've learned is that actually it's better to use multiple fields to make sure that you're aiming the field so that the distal edge is not placed into the critical structures that you're trying to protect. It's better to have kind of the lateral penumbra. So now we use, instead of kind of the passive scatter technique, we use multiple fields. We often use pencil beam scanning, making sure that we're aiming the beam appropriately. And there's a new strategy for kind of directly calculating what is the LET, what is the linear energy transfer, or the RBE at that distal edge, and controlling it. And it's really about controlling hotspots. Protons compared with photons are also a little bit more finicky. They're more sensitive to anatomic changes. If there's swelling, if there's weight loss, if there's different aeration of the mastoid air cells, that can all impact the proton dosimetry. So it's important to pay close attention to your cone beam CTs. Next slide. Okay. What about the benefits? I spent a lot of time talking about the caveats, but you can see protons on the left and photons, intensity modulated radiation on the right. So the protons actually have very similar high dose conformality. You can see like the red and the orange and the yellow, those are pretty similar between protons and the photons. The advantage of protons is really in the blue, the green, and the purple. And those are kind of the lower dose isodose lines. And you can see for protons, it's just much more compact. You can control where that goes. The fall off is much faster. Whereas in the photon group, you can see patients, have radiation that's going to the brainstem, that's going to the cerebellum. Further down when you're doing elective nodal coverage, it'll go into the oral cavity. And so this can have impacts in terms of our expected toxicity. It doesn't tend to impact, necrosis rates as much because that's a high dose conformality problem, but it can impact other things that influence quality of life. Go to the next slide, please. This is a phase 2 randomized study of protons versus photons for lateralized head and neck cancers. It included a number of different histologies, including parotid cancers and skin cancers. And what we found is that the patients treated with protons had lower rates of grade 2 mucositis, lower rates of dysgeusia. They, in general, had better patient-reported quality of life outcomes, and there was no difference in terms of the local regional control. So I think this highlights how the proton therapy can translate into improved quality of life for our patients, and it's exactly the way that you would expect. It's kind of reduced toxicity from that low-dose scatter that you might otherwise get with photons. Next slide, please. There's a little bit of potential downside. This is a study looking at oropharynx cancer patients. There are just many more of these than for the lateral skull-based patients, and so but it's helpful for looking at protons versus photons. And what we found was that actually the protons had a little bit of a higher rate of osteoradionecrosis. And I think, again, this is due to that higher LET RBE in the bone. And that's, for the oropharynx, when you're worried about the jaw, the jaw is usually not in the field, right? But for the lateral skull base cases, the temporal bone is in the field. It's not avoidable. You can't aim around it. You can't just reduce the dose to that area without underdosing what you're trying to treat. And so I think this is something that is worth considering when deciding between protons and photons. I will note that there was no difference in terms of the high grade events. So this is just any grade osteoradionecrosis. We see the same thing for even higher LET charged particle therapies like carbon ion. They had like a 15% rate of osteoradionecrosis in one series. So again, I think this is addressable. Often when you're reading the papers carefully, you will find that many of the older series use passive scatter, single beam. Many of the newer series use pencil beam and multiple fields. And so this is something that we're actively trying to mitigate through careful planning. Next slide, please. Okay, so I think integration with systemic therapy is really, especially for cutaneous squamous cell carcinomas, this is a really exciting area. I find that it's a very confusing area as well, especially for cases where we start off with immunotherapy and there's kind of an equivocal response. We don't really know what to make of it in terms of imaging. Sometimes the imaging is not concordant with the final pathology. And so how do we navigate what to do once we've started with immunotherapy? So this is certainly an area I think where we'll learn a lot more in the coming years. Dr. Akave talked about C-post and adjuvant cemiplimab. I think this is something that we should all refer patients to at least talk with a medical oncologist about in terms of that disease-free survival benefit. For unresectable cases, I wanted to talk about a trial that we completed that I think is exciting. It's, again, a little bit provocative. It's still early, but if we can go to the next slide. So this was the Rampart trial. It was a single-arm phase 2 study led by Chris Barker, one of my colleagues. And it was looking at patients who had unresectable cutaneous squamous cell carcinoma, and they all started with cemiplimab. It was response adapted, so if they had progression, they got treated with radiation after 2 cycles. And if there was no progression, then they received another 2 cycles of cemiplimab, followed by radiation with concurrent cemiplimab, and then adjuvant cemiplimab. And so this is a study that we've recently presented, Dr. Barker recently presented, 34 patients, so small, but almost all patients completed the radiation. 85% of the patients were on the top arm, completed 4 cycles of cemiplimab. And at 18 months, the event-free survival was 86%, which for definitive, compared with standard chemoradiation for cutaneous squamous cell carcinomas, I think that is substantially better than what the historical control rate should be. And so I think this is a really provocative data. I think, we still need to kind of investigate this a little bit further, but at least I think we've seen some really good responses to this kind of combined modality strategy. Next slide. Okay, so I think for early stage cancers that are resectable, I often think that surgery followed by radiation is kind of the preferred approach if we can do it, and then definitive chemoradiation with systemic therapy is reserved for patients that have unresectable disease, or it's the patient is declining resection. The facial nerve and the perineural spread is often a primary concern for these patients, and so the imaging I think is really helpful. I like to look at both the preoperative and the postoperative imaging and discuss with the surgeons. I think protons are, there's increasing evidence that it can be helpful, and I think lateral skull base is a very compelling site for protons because it's unilateral. So, being able to control the exit dose can substantially reduce kind of the central dose to other uninvolved structures. And I think we'll learn a lot more about some of these newer systemic therapy combinations in the coming years. Thanks so much.
Awesome. Thank you very much. To finish things off here, we have Dr. Deep, who you alluded to, and he'll be talking about some of the challenges of rehabilitation and survivorship. He's from the Mayo Clinic in Arizona, Phoenix, Arizona.
Thank you, Nathan. Thanks for the opportunity to present. I'll sort of take it from the patient's been treated and what are the circumstances that we sort of inherit in the neurotology clinic. Next slide, please. No disclosures. So these patients, as you know, while as a neurologist, we don't initiate the oncologic care, we certainly see these patients oftentimes lifelong. They have a lifelong surveillance issue and a rehabilitation problem. A lot of the wound issues and hearing considerations fall in our lap. And so that's what we'll discuss today. Next slide. So I've broken this up into the 2 different ways that these patients present to our clinic. More common scenarios, they come in with a closed off ear canal, either a lateral temporal bone resection where the ear has been primarily closed off or a flap has been used to close things. So in those cases, the middle ear and mastoid have been obliterated, the eustachian tube is occluded, so there's no communication with the upper air digestive tract. And this, of course, comes with a maximal conductive hearing loss. And then the second group of patients are those that have an intact ear canal. So those that are treated with primary radiation or some of the pre-auricular facial squamous cell cancers that just involve part of the cartilaginous ear where the resection's been done, radiation's been given, but the ear canal is still intact. And so these patients are oftentimes the ones that present with more complicated wound issues, particularly osteoid necrosis of the ear canal, as well as sometimes chronic middle ear effusions and conductive hearing loss that we'll talk about. Next slide. So we'll talk about this first kind of patient, which is the ones that come in with the intact ear canal. This is your typical patient. He's had prior treatment, surgery, radiation. The meatus can be sometimes stenotic to some degree, but oftentimes when you look inside the ear, next slide, you have this chronic issue with osteoid necrosis. So you see some bone exposed, and it doesn't take much. A single use of a Q-tip or a deep scratch or a poorly fit hearing aid that disrupts the skin barrier just never heals. These patients can have keratin debris that builds up due to the non-self-cleaning nature of the ear after radiation. The devitalized bone just creates this secondary infection, and it can lead to chronic issues. And so one of the first things that we always counsel patients on is just being extremely careful. Just nothing goes in the ear. Next slide. When managing osteoid necrosis in these patients that have an intact ear canal, truly less is more. oftentimes we're seeing these patients back for serial debridements, and it's important to be conservative. It's not, you don't want to try to get every single crust out of this ear. In fact, if we can get to a stable crust that covers the bone and we can get it into a dry ear canal, that's a win. Oftentimes, the alcohol vinegar rinses is a staple. It helps acidify the ear canal, create a pH balance that prevents bacteria and fungal infections, and so that can be really helpful. We'll apply gentian violet to any of the exposed bone, again, just to reduce the risk of infection, because the infected bone is not going to heal, and it's going to lead to chronic issues. Sometimes Trentol and vitamin E, as is used with osteoradionecrosis of the jaw, can sometimes help. And surgery is, really a last resort to be considered. Again, these are patients that have issues with wound healing, and so more surgery, creating more wounds, is rarely going to be the best first option. But sometimes it can be done to, incorporating vascularized tissue just to close things off. Next slide. It is important when you're seeing these patients back to always consider the fact that they could have some recurrence. So biopsying, a biopsy may be necessary, maybe multiple. It's important to biopsy the base because the granulation tissue that's more superficial will lead to a false negative. CT scans and PET scans can sometimes be misleading. They can't always differentiate between osteoradionecrosis versus tumor, and a PET scan that shows a hot skull base, again, might be a false positive in the situation of osteoradionecrosis. Next slide. From a hearing perspective, many times after radiation, patients will develop a conductive hearing loss due to eustachian tube dysfunction and subsequent chronic serous otitis media. So the reflex here would be to put in a tube, but I would caution against that because that tube eventually will just lead to an infected middle ear. And now these patients have a chronic suppurative otitis media, foul-smelling ear drainage, and they're still not hearing very well. And so in these cases of patients with chronic ear effusions, it's a much safer option just to bypass it with a bone conduction hearing aid, or if it's a mild hearing loss, a very carefully fit conventional hearing aid. Next slide. Moving to the next scenario, the more common scenario, those with a closed off ear canal. These patients can still have osteoradionecrosis of the residual temporal bone. They'll present with deep otalgia. Sometimes they can develop fistulas. I've seen one recently with a fistula with the glenoid fossa. They can develop fistulas with the postauricular skin. So that skin can eventually break down, but the risk of that is significantly reduced with closure with a vascularized flap. So if we're closing off the meatus primarily, I'll swing down temporalis muscle. If it's a larger defect and the head and neck team is involved, then we're going to bring some vascularized tissue, either a submental flap, radial forearm flap, some of the things that Dr. Wax talked about. So the key here is vascularized tissue to help reduce the risk of complications related to the osteoradionecrosis. Next slide. From a hearing standpoint, as I mentioned, these patients are going to have an expected maximal conductive hearing loss of 60 decibels. That's again assuming they have a good cochlear reserve, their bone line is good, and they're going to do very well with a bone conduction hearing aid. It's going to bypass the closed off ear canal. Next slide. After radiation, patients are at risk of having progressive radiation-induced sensorineural hearing loss, and that's just over half of the patients in a recent meta-analysis. And that risk is twice as high if chemotherapy is combined with radiation. And that matters because the bone line, the degree of cochlear reserve does impact our decision-making in terms of what kind of hearing rehabilitation prosthesis we can offer. Next slide. So broadly, we can offer traditional hearing aids, bone conduction hearing aids, and even cochlear implants. Next slide. So a conventional hearing aid can be considered in patients with mild to moderate hearing loss. Of course, it requires an intact canal. And again, in patients who have had prior radiation, it's very important to have them carefully fit. Alternatively, we can bypass the ear canal altogether, or if they don't have an ear canal, using the bone conduction hearing device. And that's really going to be the workhorse in a lot of our patients with lateral temporal bone resections. And then cochlear implantation is for patients who no longer benefit from a conventional hearing aid or a bone conduction hearing aid due to poor cochlear reserve. This does have some indications, and this requires careful patient selection. There'll be a slide on that in a moment here. Next slide. One note on bone-anchored implants. So there's two different versions, percutaneous versus transcutaneous. The percutaneous is sort of the tried and true, the abutment that comes through the skin. And in my practice, this really is like sort of the default for patients that have temporal bone cancers or have had a prior lateral T-bone resection. It's a short procedure. It's literally 5 or 10 minutes that can be done under a local anesthetic, all to a 5 mm hole punch. The screw itself is titanium, so there's no ferromagnetic properties, doesn't cause any magnet artifact, which is going to be important when you're thinking about surveillance of these patients long term. The transcutaneous devices were developed because these percutaneous devices do have issues with skin infections. And so the transcutaneous devices have a magnet to retain the hearing aid portion, which is very nice. It's just that it does require a magnet, and that's going to result in significant MRI artifact, which can block your view of surveilling the remnant middle ear mastoid, but even the parotid bed. It also requires a larger incision, more tissue manipulation. The magnet itself, if you're not careful or if it's too strong, can result in a wound breakdown, all things that are going to be more common or theoretically greater risk in patients who have had skull radiation. And so for those reasons, I tend to stick towards the percutaneous devices in these patients that have had prior surgery and radiation for and need ongoing oncologic surveillance with imaging. If I am doing the percutaneous device, it's my preference to put it in at the time of the initial surgery before the skull has been radiated. But if it's the patients aren't quite sure or it happens later, I'll usually I'm doing it after the radiation that I'm going to be letting this implant sit for about 6 months before I load it. And the reason for that is that the osseointegration failure is going to be the highest in patients that have had prior radiation. That risk is about 5 to 7%. Tell patients, if it does happen, it's not the end of the world. It's a little bit, it's more of a bump in the road. The tissue heals up pretty well over that, and they can always be replaced. Sometimes we'll put a sleeper device, which is a separate implant right next to the first one, just in case it does happen. There's another one that's already kind of been marinating in there and osseointegrating. And so it's just one consideration. And then lastly, next slide, cochlear implantation. I can't say that I've had a lot of patients with this, mainly because cochlear implantation is mainly in patients with bilateral hearing loss. Although, and in many of these patients with T-bone cancers, their other ear is okay, and they're not struggling too much. But if a cochlear implant is indicated, meaning their hearing aid is no longer providing benefit because of speech clarity issues, and same with the bone conduction hearing aid, the cochlear reserve is not adequate, and a cochlear implant can be considered. It does require a fluid-filled cochlea and an intact nerve, and so if the patient's had a major subtotal T-bone resection where the oda capsule has been resected, or surgery was done many years ago and they've had a heavy dose of radiation causing ossification of the cochlea, it could limit our ability to place a cochlear implant. And we use MRI to assess for that, but it is a consideration. So I will end there and hand it back over to you, Nate. Thank you.
Awesome. I cut you off on the ossia and the bone, the transcutaneous. Do you want to talk about those? I'm sorry about that.
No, I think I did. I addressed it.
Okay. Yeah, so that's what we have for today. We're pretty close to the appointed time here. I'm going to hand it over to Dr. Den and Dr. Haynes, and I really appreciate being asked to do this. I really want to thank the panelists for their excellent contributions and making this just a really, really great thing that hopefully just provides a really nice up-to-date state-of-the-art talk on this difficult and multidisciplinary topic.
Thank you so much, Nate, for an amazing job being the moderator of this very interesting topic. All of our speakers, what amazing talks. I wanted to end by thanking all of the audience for coming and enjoying our webinar. And we wanted to end with a message from Dr. Sarji about NASBS. Go ahead.
Thank you, Dr. Din, and thank you everybody from joining for joining from all over the world. I would like to thank our sister societies and our panelists. I would like to thank Dr. Din as organizer, as well as the panelists and the panel moderator. Please come and join us. Save the date for the North American Skull-Based Society annual meeting in Nashville, February 26 to 28, with a very interesting pre-meeting education day that I will let Dr. AHNS describe. This is co-sponsored by the ANS. If you're not a member of the NASBS, please consider joining. There are several topics, many that are cancer related and others that are related to lateral skull-based non-malignant diseases. So please become a member and come and attend the meeting. Thanks again for joining tonight, and back to you, Dr. Din or Dr. AHNS, for a final announcement.
I'll let Christine describe this meeting. This has really turned out to be a wonderful opportunity to partner with the NASBS on this pre-day, where the entire day will be discussing all things vestibular schwannoma and NF2, and it really has shaped up to be a fantastic meeting. Please join us in Nashville for this pre-day and for the entire NASBS meeting. So, Christine, I'll let you finish.
Yes, thank you. So NASBS usually hosts a pre-meeting education day on the Thursday before the meeting. And this year it is on February 25th, 2027 in Nashville. And we're going to have 8 hours of amazing content on vestibular schwannoma and neurofibromatosis type 2 or NF2 related schwannomatosis. We're going to talk about breakthrough science, multidisciplinary collaborations, and patient-centered innovation. I hope you guys can all join us in Nashville. With that, I'd like to thank all of our moderators, all of our speakers, and our sponsors for this event. I hope you guys all enjoy the rest of your night.